You did a series of articles on the cost of healthcare, particularly the changes in health insurance,
Yep.
The effects on families, and then also what might have been driving those costs and the increased costs on the family. There's several things that I want to get into, but the first thing I just want to ask you and just have you, talk openly about, why did you pick it? Like, where did the idea come from, and why did you choose to pursue that?
I think you and I have talked about this in the past as well,
Sure.
and certainly it's no secret that healthcare costs are of preeminent concern to Americans, and particularly Americans with job-based health insurance. And I, like many of my colleagues who write about healthcare, would hear these stories of, Americans struggling with medical bills. Even surprise medical bills obviously have gotten the most attention, but medical bills in general. And I mean, while we have kind of fought over and debated the Obamacare and what it meant and what it didn't mean, whether it was going to be repealed or not, there was, this quiet revolution really that happened with job-based health coverage, where deductibles just have gone through the roof in the last 10, 15 years. And we wanted to sort of dig into kind of practically, personally, what did that actually mean for Americans, and how were they dealing with this, pretty dramatic cost shift onto working class American households.
I really like the way you put that, particularly the quiet revolution, that what we're generally talking about in this conversation are not the poor who are on Medicaid,
Right.
Not necessarily people who are even on Obamacare, not the elderly on Medicaid or Medicare. We're talking about working people who often have insurance and are still being crushed by
That's right.
the cost.
And the healthcare debate in this country in the past was primarily about covering the uninsured. And I mean, that was obviously the driving force behind the Affordable Care Act. And it has been largely what the fight has been about since then. Whereas job-based, employer-based health insurance was, as you know, historically the gold standard. I mean, the notion was sort of that if you had a job that provided health benefits, you were doing what you were supposed to in this country, and you could expect a certain level of protection for you and your family. And clearly what's happened, and what we wanted to get into, was there's been an erosion in that, in what protection job-based coverage offers.
I feel that you did a really great job of taking aggregate national averages and distributions of data, but also seemed to be polling. You were also talking to families. You were also talking to other actors in the environment, and was all brought together. So talk a little bit about the process and sort of how you went about getting this done, because it was an incredibly rich series, and I think a lot of work went into it. And I'd like other people to hear about how that happened.
Yeah. Well, it was a lot of work.
Yeah.
I mean, the way I think about writing about healthcare and health policy specifically is, what we in newspapers I think can do is we can bring together data with the sort of lived experience of Americans, and the three components that I really wanted to pull together here was, I wanted us to have obviously real people. That's sort of a core of what journalism is about. But we didn't just want to have anecdotes. We wanted to have anecdotes that were backed up by really solid data. And polling is part of that story, and so we did do a national poll. I'll talk about that in a second. But we also wanted to bring in what the academic literature said, because polling in and of itself is a part of the story, but not the full story. And there is a really robust literature out there now about sort of what the impact of cost sharing is on patients, the way they seek care, even on their health. And so we really wanted those three components to be brought together: data and polling, academic research, and of course real people. So yeah, it was a project that we couldn't have done on our own, I don't think. We could have found stories, and we could have written stories about people suffering. But I think without having that really robust kind of foundation of data and research, it just becomes another story.
But the other thing you did is you did international comparisons. You had your results and your impacts on the family, but also you went and did your analytics with the polling, did your analytics with HCCI, but you also had some international comparisons in there, and that was a really good angle.
That was a fortuitous, actually, development, because I was doing a separate fellowship with the Commonwealth Fund, looking at actually pharmaceutical pricing policy in Germany, and while I was there on that fellowship, I squeezed in a few extra days of reporting to go and visit clinicians not only in Germany but in the Netherlands and the UK. Again, just to bring it back to what I was saying at the outset about the idea that this was a story hiding in plain sight, we sort of know that our experience is different, but once you actually kind of get on the ground, talking with patients in the Netherlands or in Germany about their experience, it's just, it hits you in the face just how unique we are.
and it really does, and that's why I also wanted to make sure that I drew your attention back to that, because this is stuff that I look at, and I know the international comparisons from a numbers point of view, and I know what's happening in the country, and why I thought this series of articles was so good. But the two striking things about the international comparisons, and particularly people who had been in a different country and then come to the United States, is first of all just the fact that they don't think about it.
Yep.
It is not a source of anxiety for them. They don't avoid care. When they have a problem, they go and get it taken care of. And the difference in the burden that they have to carry versus what.
I'll tell you, just a quick anecdote about interviewing patients in other countries. So I would go and sat with a family physician for the day in the Netherlands at a sort of small family practice. I was at a oncology clinic in a hospital in Berlin, and then I was at a acute care, hospital in London in the NHS, as well as and then I spent another day at a community outpatient clinic in the East End of London. And I must have probably sat through, between the three countries, I don't know, maybe 30 or 40 patient interactions. And at the end of each one of them, I would ask them basically two questions. I'd say sort of one, what were you most concerned about when you came into the doctor today? And people would say the sorts of things that you'd find out if you asked an American patient, that worried about pain in my abdomen, I want to make sure it's not anything serious, or I'm taking a new drug, I want to make sure that I'm concerned about any interactions, I have a sore throat, whatever. And then at the end, nobody would mention cost, which obviously is very different than what I think the experience you'd get asking Americans that question. But then I would ask them, did you think about, were you worried at all about how much this would cost? And I joked when I got back from that reporting trip that I might as well have asked them, how's your pet penguin? Right. I mean, they looked at me like I was nuts, and it's just not, doesn't even sort of register as a part of the equation of seeking medical care.
It really comes through in the article about how different. And then just to stick with the international stuff for a second, or for the international comparisons for a second, and the other thing that I thought was interesting is, like other people, you did your analytics, and the differences in many of the quality outcomes are poorer in the U.S. than not one for one. There are some places where the United States does better, but general life expectancy and that type of thing is better in these countries that spend less money. And then also the argument, and you should comment on this, the argument of, yes, but your wait times are so much longer, which it was true sometimes, but certainly not all of the times.
And this is another, Commonwealth Fund. There's so many great resources for reporters, for researchers, and the Commonwealth Fund for years has been collecting data on health system performance in other wealthy countries, and they pull from multiple sources to sort of to do it in these report cards. And yeah, I mean it's striking because there is this mythology that, oh sure, there's a trade-off, but when you look across the board on cancer survival, on wait times, on access and so forth, it's so much better here. And as you noted, I mean, there are some acute care measures, for example, how survival rates post cardiac inpatient care that are better in the United States than they are, for example, in the UK. But it's not the case, as you noted, that's across the board. I mean, if you look on some of these process and outcome measures, they're better in the Netherlands or in Germany than they are here or in Australia. And so, it just puts a lie to the argument that we are getting something in return for paying more out of our own pockets.
Yeah, and I think it was, and sorry to mention another newspaper, but I read something either in the Post or the Times, New York Times,
yeah.
Yesterday, day before, there's sort of a hidden $8,000 tax in the United States, and then when you look at survival rates, it's sort of what are we getting for that? Was there any particular interview, and there were many poignant and striking stories, so this might be an unfair question, that jumped out, or anybody who wouldn't talk to you that would be interesting, or any part of that process that you want to make any comment on before we go on to results?
I mean, so, I probably talked to easily 150 patients around the country over, for the piece. And visited with people in their living rooms and their kitchens, around the country for it, and my major takeaway from the experience of having those conversations, as well as looking at what we found in the poll, because we gave people, this was a little bit unusual for our poll as well. We gave people an opportunity to volunteer information. It was we had open-ended questions. One of which was, if you've had to make a difficult sacrifice to pay for medical care in the last year, describe what it was. And, I think all of us were prepared for to see the scale of the problem in sort of percentage terms. There have been other polls that have, have asked about this. Mm-hmm. But I don't think, I certainly wasn't, and I don't think the Kaiser people were either, and they've done a lot of polling on this too. We were a little bit overwhelmed almost by the scale of the suffering, really. And again, I mean, I think there was this sort of quality of desperation and hopelessness that we sort of confronted. And happy to go into some of the stories if you want, but I think the poignancy of this, the difficult choices that people were having to make, cutting back on food, or a mother who couldn't go see her son who was home on shore leave from the Navy because she couldn't afford to get to Norfolk or wherever it was, or grandparents who couldn't afford to get their grandchildren Christmas presents. People who had to move in with friends. I don't know that if you are not living that level of stress, it's almost hard to understand. I mean, for us, most of us have pretty good paying jobs, and we have a cushion, and God forbid something horrible happens to us, we sort of live with a certain amount of confidence that we'd be able to weather this, and needless to say, there are millions of Americans who are living on a razor's edge, and at the first unexpected medical emergency, everything can be upended, and that was really and really sad, and it's always sad. I've been a reporter for 25 years. Before I covered healthcare, I covered criminal justice and other things, and ran into, God knows, I can tell you the tragedies that I've covered, but there's something almost more disturbing about talking to people who who are working and are sort of doing what we as in this society say that you have to do. These are not people, and there are many reasons why people don't work and are reliant on government programs. Many of the times it's not their fault at all, but these are people who are doing what we say. We say go out and get a job. They go out and get a job, and yet their kid gets sick and they're having to go on GoFundMe.
This is exactly why I wanted you here, because that is the takeaway from the article. I mean, times we're talking to family. We're talking to families who are making $80,000 and are just buried with these bills that have come because the kid had an issue, or one of the husband or wife had an issue, and it's exactly what you said. It's just kind of pulled down the entire framework. This was not in your story. For some reason, this particular anecdote always bothered me, and there's much more significant ones out there. And I probably won't tell it right, but it's the woman who drove, and I'm sure you read it. It's a woman who drove her daughter to the emergency room because she swallowed something and she was unsure whether she was going to have an allergic reaction to it, and sat in the parking lot and waited to see if there was going to be a reaction because she already had bills she couldn't afford from the emergency room. And like that kind of anxiety and that kind of behavior was just like I don't understand why somebody with insurance working.
I'll tell you,
Please.
one of the people that we interviewed was a lawyer in Minneapolis or St. Paul, in Twin Cities, and this was a guy who they were a six-figure family, and they had a high deductible plan. And they actually were not drowning in debt or anything like that. But I remember he told me, he said, I hated myself as a parent to feel like when my kids got sick,
I remember
I worried, I would think, do I really need to take them to the doctor?
Exactly.
And I mean, it resonated for me. I mean, I have two small kids, and we had high deductible coverage for a long time, which, was a pretty good deal for us, which is, probably something we can get into later about the sort of, unfairness of this way of structuring health insurance. But anyway, even though we could tolerate a pretty high level of risk in my house, I mean, I would have these thoughts sometimes too about, like, do I need to take her to urgent care? Or, can we do it can we wait another 12 hours and see if she gets through the night? That's just, it does. It makes you feel like you don't want to ever think like that as a parent, even if you don't ever do it. And I don't think he ever withheld care from his kids. And said, tough it out. But he found himself thinking that way, and it's so corrosive.
I agree. I think something that comes through, and something we're seeing in our work, and something that we're very concerned about, is there is rationing occurring. This is another charge about looking at other countries. Yes, but they ration care. And the notion that it is not happening in this country among certain types of people of different incomes with different, or with certain kinds of medical issues, it is happening. And the rationing that I read from your pieces kind of came at me in two ways. One is the medical stuff we're talking about.
Yeah.
I'm not sure I'm going to go to the emergency room because I can't sustain the bill.
Right.
But the other kind of rationing, and maybe this is part of your kind of quiet revolution of, I'm raiding, or I'm not saving for the kids' education. I'm cutting back on food. We're not buying the house. We're
right.
Like that. It struck me very clearly that the rationing was occurring in a couple of different ways, both medical and in other.
No, that's right. I mean, so we found in the poll that half of Americans with job-based coverage said they or somebody in their family had not sought medical care or not filled a prescription in the last year because of cost. So, I mean, that's pretty substantial. But the share who said we made a difficult sacrifice, such as cutting back on food and housing, taking on extra work, moving in with friends and family, 1 in 6. I mean, 1 in 6. And again, I mean, these are people who have health insurance.
Right.
So, people were saying I ate like a bird sometimes. When I interviewed one woman who was a nursing home aide in, I think it was Ohio. who said she said, well, at least I get fed at work.
I remember that
You
line.
know,
Yeah.
And sometimes you kind of think it's a little barbaric.
It is, and I think part of the reason that the drug debate has gained so much traction is people suddenly became aware that the rest of the world wasn't paying these kinds of prices. And I think if there was some more generalized understanding that, we're also paying top dollar for hospital and physician services, and our insurance is structured in such a way that we carry that risk, maybe the same kind of.
Yeah, I wonder about that. I mean, one thing which partly the experience of reporting in Europe got me thinking about, but also more generally our project, if there's one thing that's, the high deductible revolution has wrought, that is marginally positive, it is that it's sort of, it's blown up the dirty little secret of American healthcare, which is that, hospitals and an unfortunate number of physicians, as well as certainly drug companies, have been charging these exorbitant prices for their services. And while we had $200 deductibles and we didn't have to really worry about the cost of that stuff that much before, those of us who had health insurance, now we're sort of seeing this. And I'm remembering the family outside Indianapolis that we interviewed in the story we did about shopping, where she had a miscarriage and called the local hospitals to get a price quote, doing what she was supposed to do as a shopper with a high deductible health plan, and was quoted like a $900 cost for this simple outpatient procedure that takes about 15 minutes, and then got a bill for like $6,000.
Right.
And was flabbergasted when she finally succeeded in getting an itemized bill with like 23 items on it, for every anesthesia and the anti-nausea medicine and the liter of sterile water that was used in the procedure, and the 15 minutes in the recovery room. And she said to me, she said, how the heck are we supposed to know to ask to shop for all of those things? But she all of a sudden realized, she and her husband, so this is how they're doing it. It's the $800 toilet seat at the Pentagon.
It jumped right out. Now what I want you to do is just take a few sentences for a minute for thinking of somebody who doesn't follow healthcare like you do, and just articulate and I think the term you used was the deductible revolution. So the clear thing in your reporting was about the shift in the way insurance worked, and you wrote about that extensively and through a couple of different articles in the series. So is in any way you want to express it, sort of say that to people who might be listening, like, what's he mean by that?
So, when you look at the numbers of what the average deductible is for job-based health coverage in this country over the last 15 years, about 12 years ago it was about $300-something for a single plan. So $300 before your insurance kicks in. And now it's $1,400 average. And of course, many people will know that $5,000 or $10,000 is not uncommon, especially for family coverage. And at the same time that that's happened, if you look at financial data of Americans' financial health, so I think it's the Fed does a survey every 3 years.
I know where you're going.
Of people's financial behavior. The share of Americans who can afford a $2,000 unexpected bill of any kind is basically not moved in the last 10, 12 years. So through the Great Recession, through 10 years of recovery, now through a couple of years of wage growth, the share of Americans who can afford a $2,000, only about half of Americans, have access to $2,000 in liquid assets. And so, it doesn't take a Nobel Prize in economics to realize that if people are having a hard time saving for their kids' college and a hard time, putting money away in a rainy day fund, at the same time that they're being asked to shoulder a greater amount of risk, financial risk in their health coverage, like something's not going to compute. And so, there's been this massive shift of risk. And I mean, I think the interesting thing is that if you look at the data in terms of what people are paying out of pocket, writ large for 300 plus million Americans, I mean, the share that Americans are paying out of pocket, hasn't moved that much. But, when you get down into kind of what's actually happening out there with people who have coverage, and then you think about the rationing that's going on, people are shouldering more of this burden. They're not paying sometimes because either, they're declaring bankruptcy,
Right.
and hospitals are reporting more and more bad debt from insured people. Some hospitals are suing people to get the money. But, the root of the high deductible revolution was this idea that, had been floating around kind of conservative health policy circles for decades, that, the thing that was missing from American healthcare was the kind of market dynamics that we have, in televisions and hotel rooms and airplanes, and that if everybody was free to shop around for services, patients would become engaged consumers, and they, with some skin in the game, would exercise market discipline on the healthcare market. And when they were comparing doctors and hospitals and prescription drugs, that would force doctors and hospitals and drug makers to moderate their prices in the same way that airlines have had to compete for business. Well, this idea was kind of on the fringes of health policy for, as you well know, for decades.
Sure.
But really, what kind of brought it to the fore was the backlash against HMOs 20 years ago, and employers were hearing it from their employees who didn't like being told they couldn't go to this doctor or that doctor. Health costs were rising, and it's interesting actually. Of all places, Minnesota, there were some entrepreneurs up there who sold Medtronic, of all companies, on this idea of empowering their employees by giving them sort of these accounts, these medical savings accounts, that they could use to pay for their medical care and give them a stake in sort of choosing it. And what's interesting about that history is that the guys who were responsible for doing this, they were not sort of right-wing ideologues. They were actually kind of idealistic entrepreneurs who thought that patients deserved to have more power in the system. And what was interesting about those first accounts was that Medtronic and some of the early companies that did this funded those accounts. And so it wasn't really it was not directly
I know what you're saying.
Skin in the game for
Right.
the employees. But this caught fire. Like within a couple of years, I mean, employers all over the country were jumping. You couldn't go to a health policy conference 15 years ago without, the CEO of Whole Foods or Pacific Business Group on Health or, Wells Fargo talking about, how this was the revolution that was going to bring down healthcare costs. And, a couple things sort of, went wrong on the way to nirvana here. And it turned out that it wasn't hard for CEOs to realize that they could save even more money if they didn't actually fund these accounts and left it to employees to do it. And they had willing kind of collaborators in the Bush administration and Republicans on Capitol Hill who created tax-preferred, accounts, HSAs, to make this that much easier for employers to do. But again, the notion was, let's encourage people to take ownership over their own healthcare dollars, and let's free them to shop around. But I think the experience of I think what we showed, and what others who did a lot of the academic research that we relied on have shown, is that this was an idea that was premised on some ideas that were questionable at best in terms of how people actually behave and how healthcare actually works. Because we polled people about their experiences shopping, and only about 1 in 6 said they had actually shopped for care. 2/3 said it's difficult or very difficult to find the price of anything. And by looking at some of the data on how people were actually saving in these health savings accounts, it turned out this was not becoming like a 401k for Americans. I mean, this was becoming a tax shelter for wealthy workers who had enough disposable income to put it away, and people who are living, paycheck to paycheck weren't doing it. I mean, I think I'm gonna forget the tax data, but I think the IRS data shows that households making more than $100,000 account for maybe 20% of taxpayers, but they account for something like 70+% of the money that's been put into health savings accounts. So it's not.
Decidedly, the research went in that direction.
Yeah.
And there were things about this when you say, some other ideas or at least some other conditions that needed to be present. I mean, I think the notion that you can shop effectively for healthcare probably applies to some services. And it's when you're rolling into an emergency room on a gurney, you're not negotiating, and there are some services that are just not going to lend itself to it. And I think I believe it was the woman in your article who said, "How was I supposed to know that I was negotiating? Even if you knew you were going to the hospital, do you know that you're supposed to negotiate for your anesthesiologist, who actually, as it turns out, might be out of network anyway? So good luck."
Right.
But then also things like, is the information available to you to shop? There's also just the bandwidth. I actually talked to people who had HSAs and had probably the disposable income to manage them, and to work with them. But they said the amount of time and effort that went into them, they eventually walked away from them because they just found the level of work of basically managing their own healthcare overwhelming. You also have the usual agency problem where the physician says, "This is what I think you should do," and then do you follow what your physician says, or do you go off and do? They were just like a whole. And then do you have the point you just made, the disposable income yourself to actually finance?
I mean,
this thing?
I interviewed probably, I don't know how many conversations I had with patients about sort of what they wanted to be doing, and what people would say was, "I don't want to shop for this service. I want to, if my doctor says I should go here, my doctor says I should do that, I want to trust my doctor to tell me what to do." And I don't think that the sort of the champions of the skin in the game notion, will say, and I interviewed some of them as well, will say, well, the reason why the revolution hasn't delivered what we promised is because, there hasn't been the transparency that is necessary. And that's 100% true, right? But there is a little bit of the, once the rockets go up, who cares where they come down? I mean, that's only part of the issue. I think, you're touching on
let's get into
psychology.
Yeah, well, there is that, how much does somebody, and I believe in financial incentives, and I do think people should be conscious of their consumptions, but I also think of their consumption in healthcare. I also think there's research that says you can actually get that steering with much smaller numbers than putting somebody at risk for an $8,000 deductible. Much smaller dollar amounts.
And clearly, there's been some research that's shown, CalPERS in California, for example, that you can
get people to
on the margins.
Right.
But it's not the solution for our cost problem.
Completely agree. And on that CalPERS thing, I think what that showed pretty well is just for some services.
For some services,
that are happening. You have
your
time,
imaging, your knee replacements. Sure.
Completely agree. But here was the other problem that I think rises out of all this, and I believe gets into some other things that was in this particular in your work. But the other thing that comes out of it that I feel like has been occurring over time is tremendous amounts of consolidation. So you have the drugs are a different issue in the sense that you have a government-granted monopoly, and then you can charge really high prices. The hospitals kind of did it the old-fashioned way and bought horizontally all of the hospital, or depending on the market in question, many of the hospitals. And then in the surprise billing world, which I know you know about, is you get a private equity firm buys all the anesthesiologists in a market and then says, by the way, you're going to step out and charge these kinds of prices. Part of the reason that transparency may not be enough is if I own the market, it's only going to be transparent that I'm setting the price. So if I own all the hospitals in this market and you want to shop for a lower cost hospital and I'm setting the price for all of them, being transparent is not going to particularly fix that problem.
I mean, clearly that's true. Clearly that's true. Yeah, you have to have a base number of competitors in order to have a realistic shopping experience. And I mean, I think HCCI has done a particularly good job. I think it's showing sort of what services are realistically shoppable. It's funny that one of the more amusing interviews I did when I was in the UK was at King's College Hospital, which is one of the top hospitals in London. There was trailblazing work and liver transplants was done there, 50 years ago or so. And like a lot of NHS hospitals, there is a private wing of the hospital and for private pay patients. And so, in England, everybody has NHS coverage. It entitles you to free access to care, free at the point of service. Any hospital, any emergency room, any doctor's office, it's free, but the trade-off in England at least is, your level of sort of creature comforts, would be in many cases not tolerable for Americans. There's still wards, for example, in English hospitals. So many people, particularly foreigners who work there, get private coverage on top of that. Although it stayed relatively stable, I think it's like 10% or something have private coverage. Entitles you to a private room in a private ward. And if you come to King's College to get a procedure and you're not covered by the NHS, like a foreign prince or something comes from Saudi or whatever to get this, or an American businessman, the NHS is required to charge you a price that covers the full cost of the NHS's work. And so as a result, it's imperative that they have a price for a whole list of services. And I went into the office of the guy who oversaw the private ward at King's College Hospital, and I asked him, I said, well, so you have a price list?
It doesn't exist in the U.S.
Yeah,
but
he opens the drawer and he takes out a price list, and there's knee replacement, there's kidney transplant, there's this, that, and the other thing. And I thought, irony of ironies, here I am in sort of the most socialized healthcare system in the world, one that free market American advocates dump on to no degree, and yet here you can find what the price of a procedure is, and you cannot find that at an American hospital.
It was so clear in your reporting. And I've had this experience myself, and like you call and you try and say how much, and you can't get it because they don't have it, or they can give you, well, I can kind of tell you a range, and then of course they can't tell you like anything associated. Well, somebody else is going to charge you for that. I don't know. Yeah. So I feel, and I want to be clear. I mean, I'm no friend of the insurance industry, and I think you've documented well, both here today and in your work, how the insurers kind of, working with employers, shifted the risk to working folks. But I think we're also saying, but behind all of that, there's these prices in the hospital being set by drug manufacturers, hospitals, physicians that are driving a lot of this. And others and yourself have documented the implications of that for families. It suppresses your wages. It means that other things you might be spending money on, getting yourself out of debt, sending your kid to college, buying food, whatever the case may be, are all implicated in this. And your piece was very compelling through the several different parts of it, and very saddening. And I'm very sad, and I'm being very it was very hard to read about these families struggling. But then the last one, I believe, is the last one in the series. Like there's something positive in it, and I won't. I generally avoid any kind of happiness or positive whatsoever. But I really was. I don't want to say this because it's going to be on tape. I was really happy to read that last piece on the union, and I'd like you to talk about.
Yeah, I mean, it's an amazing story. I think, in a lot of ways, and hopeful as you said, but also, I mean, the thing that struck me about it, and I'll talk about it in a second, is it so clearly illustrates the incredible power of price and the trade-offs that it involves. So this is a story about the hotel workers union in Boston that represents 5,000-6,000 people who clean the rooms and serve the meals in most of the big Boston hotels. And they have a Taft-Hartley plan. So there are many unions in this country have these kinds of arrangements where the employers kick in money to the plan, but the plan is administered by the union, and as a result, and it's negotiated together. So there's a clear the trade-off between how much employers are kicking in for the health plan and how much is going to wages is something that the union works out clearly. And Boston is a very high-priced medical market, for good reason. I mean, there's a few good hospitals up there.
Okay, I'll let that go, but go ahead.
But they're also very expensive.
They're very expensive.
And they're Harvard teaching hospitals, and people come from all over the world to get their complex care taken care of, as well as their x-rays and everything else. And this plan had kind of been limping along for a couple decades, and they would go through periodic crises where they'd have to give up wages, or they'd have to chip in a little more money to keep the thing afloat. And the leaders of the union a few years ago said, enough, we gotta stop this. And so they worked with their administrator, their health insurer that administered the plan, Tufts health plan, and they said, help us out here. We want to do something different here. And the health plan came up with some options, and they said, we can do some deductibles if you want. And it was interesting. The union leadership said, no, we are not doing deductibles. Like, our members make, too little money. Boston's an expensive city. We are not shifting risk onto them. And they said, well, one thing you could do is you could look at cutting out the very highest cost hospitals in Boston from your network. And by the way, there's now a pretty robust amount of data in Boston that shows that if you need medical attention in Boston, whether you go to Mass General or whether you go to the Beth Israel Deaconess, you're probably not. You're going to get a good outcome probably in both places. And so they modeled it out, and they said, what happens if we eliminate Mass General, Brigham, and Boston Children's from our network, and we tell our members that you can't go there anymore. And they knew this was going to be contentious, so they took it to a vote of their members, and a lot of people were reluctant to do this. They'd gotten used to going to the MGH for even a sore throat, and they didn't want to have to change. But they did it. They voted 2/3 to 1/3 to do it. And the amazing thing was that they saved so much money as a result of doing this that, number one, they were able to keep a plan with no deductible. So you go to the doctor, $0. You go to the hospital, $0. You get an x-ray, $0. Your drugs, $1 for a generic, $12 maximum for a specialty drug. And premium, $50 a month for a family plan. And the average in the United States for a family plan, I think, is about $500 a month for American workers. So 1/10 the cost premium. And most profound, I think, the average hourly wage for a housekeeper went from like $17 an hour to, I think, almost $24 an hour in like 5 years. And this was, the union leadership was very clear about how they said, you know what, we know that more money in people's pockets has a health impact. We know people are going to be happier and healthier if they're more financially secure. And we want to make sure that happens. And I think, the thing that's so those numbers are obviously, I think, pretty striking in and of themselves. But
And I really appreciate that you just went through exactly what I wanted you to say, because the outcome was just astounding.
it's astonishing. But I think the thing that really struck me was that, so we've been down this path before in this country, right? Where, HMOs were basically, the proposition was narrower choice for affordability. And American workers, in many cases, soured on that experience, I think, because, and this predates my time covering healthcare, but been doing a lot of research on it for a book that I've been doing. American workers soured on it, I think, in part because there wasn't a clear benefit to the trade-off. So, employers were telling, Mark, sorry, you can't go see Dr. Smith anymore, but it's cheaper for all of us, go get them. And, most people were like, this is a raw deal. And so I think what the union said was, we know there's a trade-off here. And first of all, we're going to get your buy-in because we're going to put this to a vote. But the second thing is, we're going to offer you something, very tangible in return for the trade-off. You're going to get more money in your pocket because it's going to translate directly into higher wages. And secondly, this I think is another key part of their story. They wanted to be sure that that their members were hooked up with primary care.
Oh, that's right. I forgot, because they actually did a lot of linkage to make sure that their people.
Yeah, and one of the things that was remarkable was that even though there is no penalty essentially for going to the hospital or the doctor whenever you feel like it, because there's no deductible, their utilization rates of like ER and so forth are still lower today than they were before they had this plan, because the other thing they offered their workers was, we're going to connect you with medical care that is meaningful to you and that really that offers you something that will benefit your family.
And I thought this was what was so powerful about the article was, and the fact that the union did this is this clear linkage between the trade-offs, and not just the medical ones. Like, I can give you a healthcare benefit that's less expensive and you don't have as much out of pocket, but you're also going to see raises in your wages. Like that was so on point. It was so good to read. And you see some of this starting to punch through in the environment. I feel like I'm starting to see among state employee health plans who actually can't just simply pass on price increases. Like, they have appropriations that they have to deal with, and they can either, gut the benefit, and they're starting to turn around and go back to the hospitals and say, well, wait a minute, why am I paying 300% of Medicare? You see it in Montana, you see it in North Carolina.
Yep.
And I'm hoping that some of these health plans where the direct linkage between the benefit and what they're paying for, their services, which was very clear to this, or became clear to this union, begins to drive some of this change more broadly. And we are decidedly out there trying to make that happen.
I think the thing that struck me about what we did was the raw deal that people were getting, and the one visit that really kind of stuck with me, talking to people, was this family outside Kansas City who had a really sick kid. He was I think he was 11 or 12, and one of these kids who was born with sort of all these complex medical conditions, and 53 hospitalizations or something in his life, and I was sitting there in their living room when the nurse came for like the once a week antibiotic infusion that Bo was his name, Bo needed to get, and the port was broken, and they couldn't get it, and they were sort of jamming this needle to try to get it into Bo's chest, and he was getting increasingly kind of agitated and desperate, and sort of pleading with his mother to make it stop. And I mentioned earlier I have small kids, and I was thinking as I watched this, how lucky I am to have kids who are healthy and don't have to deal with this. And then I thought, if you don't have a sick child, I don't think you can begin to understand. I certainly can't understand, what it's like to live with all of the stress that must come with having a really ill child as a parent. And on top of all of that stress, his parents have to do all these fundraisers. It's on top of all of the other things that we're asking parents who, through no fault of their own, are having to navigate all this because they have a sick child, and it could be a sick parent or a sick spouse or whatever. We have a system where we're demanding that they spend a good amount of their time raising money, and that's obviously a pain to do. But one thing which Bo's mom said to me, which sort of really stuck with me, was it's we get tired of going back to the same people all the time. Like, you can't go back to all of our friends and keep hitting them up for money. You can't do that. And it just struck me as
the couple of
something's broken.
Absolutely, and a couple of takeaways from that, because I'm really glad you reminded me of that. That the notion that you're working, you have insurance, and you still have to go and seek charity. And if I remember this properly, I think, and it was either that family or some other family where the husband was like, I can't do that. I can't ask for charity. And the wife was like, well, I can, because,
right. We got to do it.
And just the notion that we're in this country, and, some things that you said early on, I'm working, I'm doing the right thing, I have insurance, and yet I have to go out and do like the GoFundMe campaign in order to cover my medical expenses. Like, again, just another thing about your piece that was like incredibly powerful.
Yeah.
Yeah.
Thanks for having me.
I really appreciate you doing this.
Thanks,
This was a
Mark.
good conversation.
Yeah, it was a good conversation. Thanks.
Yeah.